All right, we'll pick up where we left off with our discussion of the cardiac physiology, looking at heart valves. It's important to remember the main function of heart valves is to prevent backflow of blood in the heart. For example, the two AV valves that separate the atria from the ventricles, when they are open, it allows blood to enter the ventricles. When they are closed, blood is prevented from going backward into the atria, and instead the pulmonary valve and aortic valve open, and that allows blood to leave the ventricles. So we have two different sets of valves that are important for keeping our blood moving forward through the heart. The AV valves open to fill the ventricles, and the pulmonary and aortic valves open to empty the ventricles. And each will open in response to pressure changes occurring as a result of the ventricles contracting. Something is wrong with my computer here. So looking at this diagram here, we can see kind of a top view of the different valves here. Here's the pulmonary valve, this is the aortic valve, and the specific structure of the valves prevents that backflow. And here we can see that we call these semilunar valves based on their structure is another name for them. We call them the pulmonary valve and aortic valve. But again, only the AV valves have these chordae tendineae, these collagen strings that tethers them down to the left and right ventricle, and that just provides further support from preventing them from flipping up into the atria and having backflow into the previous chamber. So it's really important that we have these valves to keep this blood moving forward, because when these valves don't close completely, that's what we hear when we hear a heart murmur. That's the flow of blood through a valve that should be closed, but some blood is sneaking through. So it can sound like a swishing motion between the normal heart sounds. And depending where that murmur occurs, we can determine if it's happening with the pulmonary aorta or aortic valves or the AV valves. So it's important to understand blood flow as it flows through the heart to get an accurate picture of true cardiac function, and to understand why the left side of the heart fails before the right side of the heart when we look at people that have vascular diseases and narrowing of the arteries or veins. So it's important to start with anywhere in the circuit where you want, but see how it's a continuous loop. So if we start with the tissues, blood returns to the heart from the body tissues through the two vena cava. We have the superior vena cava and the inferior vena cava. Now recall that this blood is coming from the tissues, so that means it is deoxygenated blood. All the oxygen has been used in the tissues, and now it's returning to the heart to pick up more oxygen. So it comes to the heart via the vena cava and enters the right atrium. From there, the blood flows from the right atrium passively into the ventricles until the ventricles are about 80% filled. Then the atria contracts. As that atrium contracts, then that blood is sent out the pulmonary artery to the lungs. So from the right ventricle, it passes through the pulmonary valve, up to the pulmonary trunk, to the pulmonary arteries, to the lungs. Notice once it's in the lungs, this blood turns red now. And recall that blood is always red, but in the diagram here it turns to a red color because this blood has now picked up oxygen in the lungs. So now we have freshly oxygenated blood returning to the heart via the pulmonary veins. So here we can see the pulmonary veins leading to the left atrium. See the four holes there? So all four pulmonary veins from the right and left lung lead to the left atrium. This is the oxygenated side of the heart. So that receives this freshly oxygenated blood. That blood then flows through the left AV valve into the left ventricle, and when the left ventricle contracts, that blood is sent out via the aorta, passing through the aortic valve to the rest of the body. So we can see the left ventricle to the aortic valve to the aorta back to the body tissues. And this is the ready supply of oxygen to the body tissues from the left side of the heart. So when we compare the circulatory systems that exist in the body, there's essentially two side-by-side systems. The right side of the heart carries deoxygenated blood to the lungs to be oxygenated. So we call the right side of the heart the pulmonary circuit because it carries blood to the lungs to pick up oxygen. The left side of the heart receives oxygenated blood from the lungs and pumps it to the rest of the body, so we call the left side of the heart the systemic circuit, or the systemic circulation, because it's sending the blood to the system or to the body. So this is the systemic circulation on the left side and the pulmonary circulation on the right side. If we compare the pressure differences of either side of this heart, we can see logically, because the lungs are so close to the heart and there's not a lot of resistance within the lungs, that the right side of the heart would be a low pressure circuit. The left side of the heart, on the other hand, would be a high pressure circuit because it's having to pump this body out the aorta to all the arteries of the body into the capillaries that feed the tissues. So this is a high pressure side of the heart, the left side, even though it's oxygenated, high pressure. Similar volumes are pumped on either side of the heart, but the pressure differences are significant from the left side to the right side. And because of that, the left side of the heart tends to fail before the right side of the heart. So if we look at how the heart is arranged in terms of muscle fibers, we can see that the rings of muscle tissue are different between the right and left sides of the heart. Here we can see the right side of the heart forms more of a spiral pattern, where the left side of the heart has more of an oblique arrangement of the muscle fibers, and again plays an important role with trying to get every bit of blood that we can with every contraction. Of course, we don't lose all the blood from the ventricles during contraction, but we lose more than half, and that's important to make sure we're getting good cardiac output to our tissues. So these ventricles respond to an action potential at the conduction points in the heart along the conduction pathway, which is the SA node, the AV node, bundle of His and Purkinje fibers. But what keeps those action potentials on the pathway are connective tissue separation. So as the AV node fires, that action potential is forced toward the bundle branches and bundle of His along the conduction pathway, which is separated by connective tissue. So we don't have rapid firing action potentials randomly throughout the heart. It's forced along a conduction pathway. So what allows a cardiac cell to be stimulated to contract is a result of these gap junctions that occur at the intercalated discs. Gap junctions allow ions from one cell to flow directly into another cell, and that is really essential to transfer that action potential from a conduction cell like the AV or SA node to a contracting cell. So we reviewed the electrical properties of the heart, and we looked at the different types of action potentials that occur in the heart. Recall that 99% of the heart muscle cells cannot generate their own action potential. They can only respond to an action potential. The other 1% are the pacemaker cells, which we find along the conduction pathway. These can generate their own action potential. Here in this example, we can see a typical action potential that we studied in the nervous system, or looking at the skeletal muscle, if we look at this negative 85 resting membrane potential. This is a typical action potential in a muscle cell. But we see something different in the cardiac muscle cell. This is a contracting muscle cell. We still see sodium causing a depolarization, but at the top of this depolarization, just as the potassium channels are starting to open, we also see calcium channels open, voltage-gated calcium channels opening, which allows calcium into the cell, which keeps it slightly positive for a period of time. This is called the plateau phase, and we see this in contracting cells of the heart, is this special phase, the plateau phase, caused by voltage-gated calcium channels opening at the peak of depolarization. So that's really something that sets these cardiac muscle cells apart from regular skeletal muscles. Then again, as we see this big drop toward resting membrane potential, this is due to potassium leaving the cell and causing repolarization. So that really isn't anything different from what we saw in our traditional action potentials we studied in the muscular and the nervous system. So looking at these special cells of the conduction pathway, remember that these can generate their own action potential. So these cells clustered along this yellow pathway represent the 1% of muscle cells in the heart that can generate their own action potential. And each area has its own rate of action potential generation. For example, the SA node can generate an action potential about 75 times a minute. The AV node is 40 to 60 beats per minute, and the rest of the conduction pathway is 30 to 40 beats per minute. So because the SA node is the fastest at 75 beats per minute, it is considered the pacemaker of the heart. So we should see a normal heart rate of about 75 beats per minute if the SA node is functioning properly. Some people have a dysfunctional SA node and other parts of the conduction pathway take over. If it goes down to the level of the AV node and that is still functional, we're going to see a heart rate of about 40 to 60. But some people, due to heart muscle damage, might find that only the ventricles and the lower part of the conduction pathway are functioning, and in that case, they're going to have a really low heart rate of about 34 to 40 beats per minute. So if we look at the action potential that's generated by these special autorhythmic or pacemaker cells found in the conduction pathway, we see a slightly different look to this graph. First of all, we see this drifting toward threshold, which occurs naturally. This is the automatic part of the action potential. This does not require a stimulus to happen right here in phase 1. What happens is at the end of the previous action potential, we see a slow opening of slow gated sodium channels that automatically open at -60. They slowly open, allowing this cell to move toward threshold. So we have some sodium moving in. Then when this pacemaker cell or autorhythmic cell reaches threshold, then calcium channels open, and calcium opens or causes depolarization. So this rapid depolarization here we see in step 2 is actually calcium entering the cell. And that's quite different from what we've seen before. With the contracting cells, we saw calcium not opening up until the top of depolarization with this plateau phase. So in this case, we have calcium causing this steep rise in depolarization in the action potential of the SA node, AV node, Purkinje fibers, and so on. So this is only 1% of cells that have this type of graph where calcium causes the major depolarization of cells. And again, we don't get to this threshold unless we have these drifting, slowly opening sodium slow gated voltage channels. So we see this slight drift towards threshold as a result of those channels opening. Again, all 3 action potentials we've studied now all have repolarization due to potassium. So that doesn't change. So what happens is we have a longer refractory period in these cells of the conduction pathway. If you notice how wide this action potential is here, it takes a lot longer for this to occur than it does the other. For example, if you look at the skeletal muscle, very narrow, very fast action potential. This one's a little bit longer, and the pacemaker's a little bit longer yet. And that allows time for these action potentials to reach the different parts of the conduction pathway. We see this allows time for the ventricles to fill between contractions. So it's important to recognize that we have refractory periods to allow time between heartbeats for those ventricles to fill, because if we had rapid action potentials, we would have a rapid heartbeat and not enough time for those ventricles to fill completely with blood. So looking at an EKG here, we can see the different parts of the EKG as it relates to heart function. So I'm going to click on this animation here, which really puts everything together. We can see the different parts of the cardiac cycle that line up with the EKG. So if we follow these heart sounds here, The S1 and S2 are the important heart sounds. The S1 occurs when the ventricles are contracting, and the S2 happens right after the ventricles relax. If we follow it on the EKG here, because the QRS, remembers when the ventricles are depolarizing just before they contract, and the T wave represents the ventricles repolarizing just before they relax. So the S1 and the S2 heart sounds are the lubbed up that we hear as the valves are closing. And if you watch where the S1 is, we can see where the valves are. So if I stop this at the S1, I can see that the AV valves are closed. If I continue this through to the S2, I can see the pulmonary and aortic valves are closed. So those represent the sounds of those valves relating to heart sounds of the lubbed up. So this is the cardiac cycle. And it's important to recognize a couple of things if you're watching this heart contract. First of all, most of the ventricles fill passively. The atria contract at the end of this passive filling phase, and that's what fills the rest of the ventricles. So if we look at the different phases here, the atria contract, and then we have this period of ejection where the ventricles contract, and that's what forces the pulmonary and the aortic valves open. And we have these periods of isovolumetric contraction and relaxation, and essentially what that is when we're in each of those stages is when the heart is a completely closed unit. Because when we look at the word isovolumetric, that means the volume is not changing. All the valves in the heart are closed. It's very important that you remember that, because that will be on the test, the different phases of the cardiac cycle. And this is shown on slide number 20. I'm sorry, slide number 25, looking at the different stages of the cardiac cycle. And on slide 26 also has a nice diagram there as well. So we have the period of isovolumic contraction. The ventricles are contracting. All four valves are closed. If we continue on, then we can see that forces blood out of the heart. Then the heart is relaxed for a short period of time, and we have a period of isovolumetric relaxation. The ventricles are relaxed, and again, all four valves are closed. And then the period of ejection is when blood is actively leaving the heart, so the arteries that lead from the ventricles are carrying blood away from the heart, and the semilunar valves of the pulmonary and aortic valves are open. So moving back then to our PowerPoint, some terminology related to the heart. Tachy means fast, brady means slow. So a rapid heart rate would be anything over 100 beats per minute. We would say that's tachycardia. Bradycardia refers to a heart rate less than 60. If the heart is beating normally, but there's periods of time during the breathing cycle that causes a slight arrhythmia, we call that sinus arrhythmia. Sinus means the SA node is properly functioning, but you have a brief period of irregularity due to the respiratory cycle causing a slight increase when we breathe of the heart rate, and then a decrease as we exhale. Some people have the atria, sometimes their atria contract prematurely prior to being signaled to by the SA node, and that can happen during times of stress, during hormone changes related to the menstrual period, or menopause. Sometimes dehydration, lack of sleep can cause those to occur, but if they occur rarely and are not associated with any symptoms, it's not usually a reason for concern. So again, looking at the cardiac cycle then, we're going to just kind of focus here in on these different cycles of the heartbeat. So we have these two periods of isovolumic contraction and relaxation when all four valves are closed. Very important to focus on that. And there is an animation for you to look at to answer some questions about this. So be sure that you know that isovolumetric or volumic means all valves are closed. The period of ejection occurs when the ventricles are contracting and blood is leaving the heart via the pulmonary artery and the aorta. Active ventricular filling occurs when the atria contract. That's the key thing to know. The difference between active and passive filling is that during active filling, the atria are contracting to actively fill the ventricles, and passive ventricular filling is when blood is returning to the heart, the AV valves are open, and the ventricles are passively filling. So in order for the ventricles to fill, they have to be relaxed. So that's another common thing to understand from the cardiac cycle, is filling can only occur when the ventricles are relaxed. So if we have a rapid heartbeat or the ventricles are quivering, as in ventricular fibrillation, the ventricles are not filling properly, and then it's not able to pump as much blood to the rest of the body. So we talked about the heart sounds already, the lubbed up sound and what valves are associated with that. So make sure you know that the AV valves closing are the lub, and the aortic and pulmonary semilunar valves are the dup. And when do they occur? The lub occurs at the beginning of ventricular contraction, which we call systole. Systole means contractions of the ventricles. And the dup sound occurs during ventricular diastole. So if someone wanted to listen to the heart valves, they could place their stethoscope over the heart and in these locations to hear them, because the vibrations as they transfer across the chest wall are slightly off center of where they would be exactly over the valves. But this is just for your information. I'm not going to hold you accountable for where to listen to the different heart valves. And that concludes our discussion of the heart in terms of basic blood flow and structure and heart valves with sounds and the cardiac cycle. Be sure that you take the quiz prior to proceeding with the online activities.